Hello, welcome everyone to the PrecisCa Lung Cancer Tumor Board. I want to welcome all our panelists today. I am Ramaswamy Govindan, a medical oncologist at Washington University in St. Louis. I'm joined today by our experts. We'll start off with the introductions. Dr. Ginsberg.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center and Professor of Radiology at Weill Cornell Medical College.
Hi, I'm Larry Keston. I'm a radiation oncologist in the Detroit, Michigan area for Michigan Healthcare Professionals and Genesis Care USA Medical Director in Michigan.
I'm Tom Stinchcomb. I'm a medical oncologist who specializes in thoracic oncology at Duke University in Durham, North Carolina.
Hello, I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
We'll be discussing the issue of adjuvant chemotherapy in this patient, a 74-year-old woman with a history of smoking. And I want to present the details now. This patient presented with right upper chest pain and was treated with over-the-counter pain medications and otherwise was in reasonably good condition, except for the history of chronic obstructive pulmonary disease, and a 50-pack history of tobacco smoking with no history of drug or alcohol use, and no family history of malignancy. And the CT scan done back in April 2019 revealed right upper lobe spiculated mass, 8 millimeter in size, and this patient was advised to undergo follow-up CT scan. So we have the CT scan from September 2019, and Dr. Ginsberg, can you please comment on this?
This scan shows a marked increase from the screening study, which demonstrates a right upper lobe mass that measures 2.4 by 2.5 centimeters. And we could see that it's extending to the pleural surface on both the axial images, and then you could see on the coronal images the same thing. What we can tell on imaging is whether it extends to the pleural surface, but it's difficult to tell if there's invasion or not. We're not very sensitive and specific. In this case, I suspect there is invasion, at least to the pleural surface, as we have loss of the fat plane and direct extension to this pleural surface.
We'll see the PET scan now.
And the PET CT scan demonstrates that this mass is FDG avid and no other lung nodules or metastases were seen on the study.
Thank you. And the biopsy was considered challenging given the location. So this patient underwent right upper lobe wedge resection with mediastinal nodal sampling, and the biopsy was consistent with adenosquamous carcinoma, moderately differentiated, measuring about 2.5 centimeters. As Dr. Ginsberg predicted, pleural involvement with positive pleural soft tissue margin. The parenchymal margin was negative. The lymphovascular invasion was present. And out of 7 lymph nodes, including 4R, 7, and 10, none of these nodes were positive. The tumor PD-L1 was deemed to be positive, greater than 1%, and had p53 mutations with no evidence of other oncogenic alteration, was deemed to have T3N0M0 stage 2B adenosquamous carcinoma. This patient underwent adjuvant radiation therapy, got standard 60 gray and 30 fractions the right upper lobe. The question really is, in 2 years' time, how would we treat this patient today? And where 2.5 centimeter, no negative, stage 3B with positive soft tissue margin in the pleural region, how would you manage this patient in 2021? What adjuvant therapy would you recommend? And before we talk about the radiation oncology and medical oncology issue, I just want to go back to Dr. Force regarding surgical resection. Can you comment on the surgical treatment this patient received, particularly the wedge resection?
Sure. I mean, we have to assume that maybe the patient had some comorbidities that prevented, really a definitive resection. We know that 5-year survival for tumors over 2 centimeters for a wedge resection, that survival is significantly worse than for a lobectomy. So the standard operation for this patient would be a thoracoscopic lobectomy with chest wall resection, and those chest wall resections can be done minimally invasive now if it's involving just 1 or 2 ribs. So really not an adequate surgical resection based on the wedge resection and the size of the tumor and leaving a positive chest wall margin. So, again, I have to assume that there may be some comorbidities that prevented the patient from getting a definitive lung resection or lung cancer resection, but we don't have that data.
So if you have to operate on this patient today, assuming you could do it, you would still do a lobectomy. What about this concept of limited resection that is coming back? There was a lot of skepticism about the wedge resection versus lobar resection. Can you comment on this issue of sublobar resection? When would this be appropriate?
Sure. I mean, there's a lot of data, as you know, and a lot of different studies. If you want to simplify it, a lot of the studies kind of point towards, and this is assuming you can get good margins, is that for tumors less than 1 centimeter or 10 millimeters, a wedge equals a segment equals a lobe for 5-year survival. Now, again, that depends on getting good margins. For once you get over 1 centimeter, between 1 and 2 centimeters, the data would suggest that a segment equals a lobe for 5-year survival, and over 2 centimeters, a lobectomy is still the standard of care because it has the best 5-year long-term survival in terms of resection.
Thank you. And one final question before we move on to systemic therapy and radiation treatment is, what is the optimal lymph node numbers that we should be looking for? Very often we see patients who come from other centers where they've sampled 1 lymph node. And what is the standard? Can you tell us?
So with lymph node sampling, I think there's 3 points. I think number 1, it needs to be done in every case. In every lung cancer resection case, a mediastinal lymph node resection should be done. So that's number 1. Number 2, I think what's most important is what lymph nodes you sample, and then thirdly, how many lymph nodes. So for a right-sided lymph node, we want level 9, which is inferior pulmonary ligament, right level 4, right lower paratracheal, and level 7 or subcarinal. On the left, level 9, level 7, and level 5 or AP window lymph nodes. So I think that just getting people to do that is the main point. We don't really there are studies looking at maximal number and what's the best. I mean, unlike other surgeries like breast cancer, there really is no morbidity from taking more nodes in lung cancer resections because the lymphatics cross over, so you don't get lymphedema. So I think the optimal number is as many as you can get. You should really clean out all those areas and take out every single lymph node that you can find. The numbers are hard because some people have a lot and some people won't. So I don't know right now that we're striving for an optimal number yet, but that's coming down the pipe in the near future.
Thank you. Looking at the positive margins, I would consider that radiation therapy would be, regardless, it'll be given in most places. The question really is that, should we give systemic therapy? If so, should we give it concurrent with radiation or sequential with radiation? Dr. Stinchcomb, can you comment on that?
And so this is a very difficult case, but unfortunately not an uncommon case. And when I sort of see these cases, I look back and I think the benefit of adjuvant chemotherapy was really in patients who underwent a lobectomy or a pneumonectomy. And so this patient wouldn't have fit the adjuvant trials to date. Also, the benefit's around 5% in overall survival at 5 years. So the benefit's real, but we have to sort of really look at the risk in each patient. And as Dr. Force has already stated, there's interaction. The people who get wedge resections many times have comorbidities that makes them a suboptimal chemotherapy candidate in many cases. I think the stage 2 disease would make you think that this patient would benefit from the adjuvant chemotherapy, because the stage 2 patients did have a benefit. When I see these cases, I'm generally fairly hesitant to give adjuvant cisplatin-based chemotherapy because they didn't have an optimal surgical resection, the positive margin, and I'm somewhat fearful of the comorbidities the patient has and their ability to really tolerate the adjuvant chemotherapy. Unless there's extenuating circumstances, most of the time I do not give it in this situation, and I realize that's a judgment call.
Would you have done something or approached it differently if the lymph nodes were positive?
I think if the lymph nodes are positive, that does sort of raise the concern the patient is at higher risk for distant disease recurrence. However, I think the question still remains about the patient's ability to tolerate and what's the magnitude of benefit at this point. So I think it's a little bit, maybe it tilts me a little bit more towards adjuvant chemotherapy if the patient's lymph node positive, but I think I still have reservations. And I think if you ask 10 oncologists, you'll get 5 different answers.
You know, it's pertinent now that we just came off from the ASCO discussion with regard to adjuvant tocilizumab. If this were approved and available, would you give this patient tocilizumab instead of chemotherapy, or tocilizumab after chemotherapy if you chose to give chemo?
Very good question. I think one that we're all struggling with. For the trial presented at ASCO, the Empower 010, the patients had to at least gotten 1 cycle of adjuvant chemotherapy, and then were randomized to atezolizumab or observation. And it looks like the patients with stage 2 and 3 with PD-L1 had a good benefit. Patients with stage 2 or 3 or PD-L1 negative had a more modest benefit. But this benefit was really disease-free survival. And I personally struggle with how much of a benefit disease-free survival is. And historically, we've always relied on overall survival as our endpoint. And I think if you really look at the stage 2, 3 unselected patients, the hazard ratio was 0.79, and the 3-year difference in disease-free survival is only 5%. And I wonder about the magnitude of the benefit of that therapy, particularly in unselected patients.
I agree. Finally, any comments about radiation therapy, Dr. Keston?
Yes, radiation therapy would definitely be indicated in this case due to the positive margin. For most cases that undergo surgery in a setting like this with negative margins, we would never typically recommend postoperative radiation treatment. But with positive margins, especially a chest wall margin such as this, it's a relatively easy treatment and well tolerated, and will reduce the local recurrence rate significantly in this patient. So they made the right choice, in my opinion, and it was a reasonable fractionation regimen as well, 60 gray in 30 fractions.
Thank you. So summarize the discussion here. The problem here, one of positive margins for somebody with no negative disease. I think the panel would recommend that these patients get radiation therapy at the conventional fraction as outlined here. The role of chemotherapy is uncertain. The role of immune checkpoint inhibitor like PD-1, PD-L1 inhibitor are still investigational at the present time.